So, welcome, guys. We've got the lovely Rea Braun with us here today. She is going to be talking through some of the pelvic floor and pelvic floor prolapse symptoms and things, just because there is a lot of that happening with hypermobility. I've asked her to come in and kind of give us a bit of an idea of what we should be looking at, as I actually suspect many of us might have some symptoms and not even realize, as that was the case for myself when I started talking to Ria about all of this. She is a fabulously trained internal pelvic floor osteopath, and she works at Fundamental Health over in Canberra. And we will hand over to her now so that she can let us know all about the things we need to know.
Perfect. Thanks, Steph. So this is just a quick presentation on hypermobility, pelvic floor and prolapse, the key things you need to know. Let me go to the next slide. That'd be great. Beautiful. So the ligaments are the key support of the pelvis. And now with the ligaments in and around the pelvis supporting us for day-to-day function, protecting us from injury and trauma, due to increased laxity in these support ligaments in people with HSD or EDS, we might see issues like lower back pain, pain in the SIJ joints, hip pain, pubic symphysis pain, groin pain, or internal pelvic pain as well. So due to this increased flexibility, there usually is a flexibility tension ratio issue, which leads to greater potential for pelvic floor dysfunction and also a greater tendency to pain. So for the pelvic floor, due to the increased range of motion a lot of people will have in their back and their pelvis, we naturally have an increase in muscle tension to grip and protect, not only through the pelvic floor, but all the associated pelvic stability muscles, because we've got 36 muscles that connect to the pelvis. So an overactive pelvic floor, which is tight, can be either strong or weak. Tension doesn't always mean weak, and it doesn't always mean that it's strong, because tension and strength are completely unrelated. So when we have increased tension, we usually see that the pelvic floor is working in a smaller range. So the way I often describe it to people is like a bicep. We're wanting it to be able to contract and relax fully for good function. But if it's tight, we're seeing a smaller little range, which is not what we want. We want to see it fully contract, fully relax, and that way we know it's going to be doing its job to the fullest. So when we have that smaller range, it can lead to a vulnerability of issues like things for the bladder, leakage, urgency, frequency issues, issues in the bowel, constipation, incomplete emptying, etc., and issues with prolapse as well. So pain often follows the distribution in this image here, usually a bit more widespread than this image shows, but local pinpoint pain internally, pain externally on touch, especially around the perineum here, referral pain down the inner thigh, lower abdomen, out to the side of the hips, near tailbone, and in through the lower back. Urinary leakage is really common in people with hypermobility, but it is never normal. So if you are experiencing any degree of urinary leakage, I strongly advise you see a pelvic health practitioner. Urinary leakage can occur due to the increased pelvic floor tension, hence limiting its range of movement, leading to fatigue and function issues. It can happen due to weakness of the pelvic floor, so it's not actually able to contract up and support the bladder or the urethra, or due to urethral hypermobility. Now, this is really, really common with people who are hypermobile. So this little image shows that usually when we see the pelvic floor contract, it supports the bladder and urethra, but with urethral hypermobility, it actually can continue descending and moving down. Urethral hypermobility also predisposes people to urethral prolapse as well. So with this increased rate of movement, it is important that we make sure the support crew are doing all the right things to mitigate and support urinary leakage, because hypermobility alone shouldn't be creating the urinary leakage on its own. Constipation is a really key one as well. So pelvic floor dysfunction can create a barrier to passing regular and easy bowel motions, as well as there is also a heightened prevalence of bowel conditions amongst the hypermobile EDS community, leading to an increased chance for constipation as well. Chronic constipation puts a significant strain on the pelvic floor, which can lead to a really vicious cycle of tension, constipation, pain, and overall heightens the risk of prolapse, especially prolonged over time, especially for a posterior wall prolapse bowel rectocele. It's got multiple names, which makes it nice and easy for all of us. Constipation can be a very manageable condition. Obviously, when there are other conditions in the picture, you often need a bit of help from your GP or pelvic health practitioner to make this more manageable, to mitigate its risk factors. Prolapse, so due to the increased range of movement, hypermobile people at their baseline are more at risk for prolapse. So a lot of people at their baseline may already be a grade 1 prolapse just due to the laxity in the wall. Now, a grade 1 prolapse is just that, a bit of laxity in the wall, whereas as soon as we look to a grade 2, grade 3, grade 4, there is descent with that wall laxity as well. So when we have the combination of pelvic floor tension, constipation, pain, this heightens the risk again, because usually we're starting to see guarding mechanisms and the body just trying to compensate and cope where it can, which may lead to prolapse. People with hypermobility often need a more tailored pelvic healthcare program, including both strengthening and relaxation, and occasionally need other interventions and things like pessaries for support as well. So there are 5 key types of prolapse. So there is the anterior wall, which supports the bladder out this way. So it's also known as a bladder prolapse. Now, it's not the actual bladder that is protruding out, it's just descending due to the laxity in the wall, which is a big common misconception, that people think their bladder or their bowel is falling out of them. Same for the posterior wall. This is a rectocele, so that is the bowel that is descending down. There is a vaginal prolapse, so this is prolapse coming down from the top. The actual vagina is starting to descend. A vaginal vault prolapse, this only occurs in people who have had hysterectomies, because it is called a vault because there's nothing there. It is the actual stitching of where they've held things up starting to dip and descend down. And then a urethral prolapse. Urethral prolapse is going to happen with the urethral hypermobility, or sometimes they do come in conjunction with a bladder prolapse, just because they are both orientated towards the top, so they usually come together. So they are graded in degrees of movement. I'm also someone who gives borderline gradings for people as well, that at baseline it looks like a 1, but when we cue you to do a lot of bearing down, it becomes a grade 2. So if you ever get given a borderline grading, it's just because we're going, it rests here, but it can become this. But what we want to do is keep it as stable as possible, because prolapses often can progress over time, especially without good management in the picture. Signs and symptoms to watch out for: if you're feeling a bulge, a drag, a heaviness in the vagina, if you're having issues with incomplete bladder or bowel emptying. So if you're feeling like when you go to urinate that you're needing to do a double void, or when you get up you're like there's still something there, and common for bowel, especially people with constipation, that you're like there's just more there and it's not coming. Urinary leakage or increased urinary urge or frequency, especially these can be paired together. Chronic constipation, if there is pelvic pain, particularly deep internal pain, this might come with pain with intimacy, but even just general pelvic girdle pain, we see there is a big link between the two as well. And painful intimacy is always a big one if you're experiencing painful intimacy, whether that be pain with sex or even just issues in putting in a tampon or a menstrual cup, even a finger, we go, it is worth seeing a pelvic health practitioner, especially if there's more than one of the above going on. There is always need to address what is happening. Things you can try at home if you're starting to meet some of the criteria that we've gone through today. Using a toilet stool is one of my biggest recommendations. It is such a good help. This aids pelvic floor relaxation when you're on the toilet, because your knees are higher than your hips and you're in a forward lean position, which kind of mimics a classic squat of what we would have done before toilets were invented. This aids pelvic floor relaxation, so then it aids complete bowel and bladder motions. Constipation yin yoga, using bolsters for support. So there are plenty of yin yoga videos out there online. You can just add bolsters and pillows for support. But the main goal is not necessarily feeling a stretch, but just relaxing in those poses to get those muscles to switch off. Because a lot of people with hypermobility try and avoid yoga because they never feel the stretch, or it feels bad for their body. But yin yoga is more about the flow and the movement and the relaxation to try and help all that guarding let go. Breath work to aid pelvic floor release and mobility. You can do this by placing your hands on your lower belly and focusing on some nice deep breathing for 5 to 10 minutes. Now, this isn't pushing into your belly protruding. It is just allowing your breath to naturally rise and fall with intention of breathing down. But you do this by breathing in through the nose, out through the mouth. We do it this way because when we sigh out the mouth, we can't help but naturally relax. It's a nice little biology hack that when we sigh, we naturally already soften our jaw, drop our shoulders, and we just want to let that flow on through the body as well. You can also do this in a seated position. You can sit on a rolled up towel for extra feedback so you can feel around your pelvic floor better. Trying to increase your water intake to minimum 2 litres a day and appropriate fibre intake to help mitigate constipation. So good fibre cheap foods include 2 tablespoons of chia seeds that equals half your intake for the day already, and high fibre fruits include kiwi, orange, avocado and banana. So they're really easy ones to try and chuck in to your diet. Now, a lot of people struggle with the increase in water intake. So I am really pro whatever you need to put in your drink bottle to make it easy to drink. Add cordial, electrolyte beverages, tea counts because tea is mainly water. Coffee can count, it just depends on your milk to water ratio, but just look at overall how much water has been in your day. But especially for people who have issues with water, even if we're looking at things like juice, trying to avoid things like fizzy drinks because they're not going to give the same water intake, but we're just looking at how can we intake enough to, one, support the muscles, but also make sure bladder function is as good as possible. Why pelvic osteo might be the better fit for you. So women's and pelvic health osteopathy has always been a whole body, whole person approach to what's going on. So we're not just focusing on your pelvis. We're always going to look at any other pains in the body, what's related to the hypermobility or EDS symptoms, and try and manage it all together. So osteopathy looks at how bones, muscles, ligaments, fascia, and organs are all involved in the picture. I personally have a really big interest in scar tissue work as well. So that's always tied in with my practice. So this includes hands-on release work, externally and internally, optionally, depending on the person, as well as doing a pelvic floor assessment to gauge what's going on and appropriate homework. I usually describe it that it's more based on the practitioner than it ever is the profession. I know some absolutely fabulous pelvic health physios, but it's all about, is someone going to look at you as a whole person and your whole body and how that's contributing to what's going on, or are they just focusing on your pelvis? It's kind of like when you go see a hand physio, they're just going to look at your hand. You go see the jaw physio for your TMJ issues, they're pretty much only going to look at your jaw. When we look at hypermobility and EDS, that type of care is not appropriate for the pelvis because there is so much more going on. So you need to find a fabulous pelvic health practitioner who will look broader at the picture for you. So at Fundamental Health, we actually have a pelvic health team of 5 now, which is really incredible. So we will always have someone who's the right fit for you based on what's going on in your life. So we have 2 pelvic physios. We have Liz, who's our senior physio, and Gurpreet, who's our junior. Both of them are really fabulous whole person focused physiotherapists. They both do a lot of work with bladder and bowel. Liz does a lot of work with perimenopause, menopause as well, and both are really great for general pelvic floor physiotherapy work. With the osteos, there's me. I do a lot of work with pelvic pain, scar management, managing any pelvic floor condition, and a lot of pregnancy postnatal work as well. Our junior osteo Kat, she does pelvic floor. She doesn't do pregnancy pelvic floor work at the moment, but she deals with issues like incontinence and prolapse as well. But she has a big interest in fibromyalgia, long COVID, chronic fatigue, which does fit into the picture for a lot of people who are probably watching this. So Kat might be a great fit for you as well. And Lauren, she's just come back from mat leave. She does a lot of visceral constipation pelvic floor work. So a lot of people who have gone through 2 or 3 pelvic practitioners and they've not been the right fit often end up with Lauren because she does more of that organ work, which can suit them really well. So I always recommend just check out bio, see who's the right fit for you, but seeing any pelvic health practitioner, if you're meeting the criteria for symptoms of prolapse or urinary leakage or any issues, I just encourage you to see someone, but always read people's bios and try to find someone who is the right fit for you. They need to be trained and interested in the areas that you're presenting with. And that's that, everyone. Just end that one. I hope that's answered a few questions for everyone. Obviously, prolapse is really individual, but if you're experiencing symptoms, you need individualized care, so please see someone.
Thank you so much, Ria. It's been great having all of that information shared. I'm really grateful because that's something that I think a lot of us needed to know.
You are all good. If there are any questions, please feel free to reach out to me directly. My email I'll chuck on the post that had the Zoom link, so feel free to send an email. But just look after yourself, see someone if you need. But thank you for having me today.